We'll now begin part 2 of the lecture on promoting healthy hearing over the lifespan. And as we finished up part 1, I was talking about the 4 different oral emittance or acoustic reflex measurements that are available to you clinically and could be used in the evaluation of any patient, adult or child, coming into your audiology clinic. And those were acoustic reflex threshold, acoustic reflex amplitude, the acoustic reflex decay test, and the most recent, which is available on pieces of equipment, very few, but the pieces of equipment like the GSI TimStar Pro, is the acoustic reflex latency test. Now we're going to talk about how these 4 different acoustic reflex measurements can be applied clinically. And this directly ties in with our discussion of promoting healthy hearing. The whole concept is that we need to be able to detect any type of auditory dysfunction when we evaluate patients in order to prevent any future deterioration of hearing. Or, on the other hand, we may provide concrete evidence that there is no auditory dysfunction. We may apply the most sensitive and specific auditory tests of the peripheral auditory system and also of the central auditory pathways, and we may conclude there are no problems. Now, that information is not of no value. It's not useless information. In a patient who has communication complaints and a patient who's having difficulty conversing in difficult situations, or perhaps someone thinks they have a hearing loss, maybe an older patient whose family members, whose children and other family members are convinced they have a hearing loss. They don't seem to pay attention. They're distracted by background sound. This person may not have an auditory problem. We may show that their auditory system is entirely normal, and therefore we need to look elsewhere for an explanation for why they're having difficulty communicating. And obviously, for an elderly patient with those kinds of problems, they're distracted, they can't seem to remember what somebody told them, somebody says, please do this, and they don't remember what the person said, then we start thinking perhaps it's not auditory, it's cognitive. So now we're going to talk about how acoustic reflexes can be applied as part of a comprehensive test battery in any patient to pinpoint the problem and therefore to be able to develop an effective management plan. The first application, which you see here on this slide, is the detection of even subtle, very, very slight, maybe subclinical middle ear dysfunction. And most people don't even think of the acoustic reflex as this application of the acoustic reflex. To me, it's one of the most valuable. If you have a patient who has never had any ear problems, never had an infection, never seen an ear, nose, and throat doctor, and they don't have any ear problems now, or at least middle ear problems, never had pain in their ears, never had draining ears, don't have any problems when they fly, when they go up and they descend, their ears never are hurting them, and then we find that their tympanogram's normal. We look in their ear, the tympanic membrane looks normal. If we want to 100% prove that they do not have anything wrong with their middle ear, then perform one acoustic reflex measurement with one stimulus, maybe 1,000 hertz. It could be contralateral, it could be ipsilateral reflex. And if there is acoustic reflex present at 80 to 85 dB, a normal level, there is no middle ear problem, period. You can rule out any problem with the middle ear because the acoustic reflex is present. The acoustic reflex is almost always obliterated, or it's not seen in any patient with even a subtle middle ear problem. So when the acoustic reflex is normal, then we can assume there's no problem with the middle ear. There's only one exception, and that is, it's not really an exception, but one case that we must consider, and that is a patient with superior canal dehiscence syndrome. They may have what looks like an air bone gap in the audiogram. They may have poorer air conduction than bone conduction, and they might still have acoustic reflexes. Technically, they don't really have middle ear dysfunction, And of course, we would know who that patient is. They would have vestibular problems. They'd be undergoing a complete balance and vestibular workup. So for the average adult, the presence of an acoustic reflex at 80, 85, even 90 decibels rules out middle ear dysfunction. And therefore, we don't need to perform bone conduction on that patient. So, and this has been known since the very earliest years of oral emittance measurements, 1970s. So there's plenty of evidence to support this. There's no problem with the eustachian tube or with the middle ear, no problem with the middle ear mechanism or the eardrum if the acoustic reflex is recorded at a normal level. Now, if the acoustic reflex is absent with the probe in one ear, whether it's the right ear or the left ear, then if there's no acoustic reflex under that condition, whenever the probe is in one ear, the reflex is not observed. Whenever the probe is in the other ear, the acoustic reflex is observed. Then the acoustic reflex is actually perhaps confirming mild middle ear disorder. In other words, the patient has an abnormal tympanogram of some type, maybe negative pressure, maybe type B tympanogram, maybe a very shallow tympanogram, and we're recording no reflexes whenever the probe is in that same ear. Then the acoustic reflex is actually confirming middle ear disorder. Whether there's an air bone gap in the pure tone audiometry or not, there is some evidence of middle ear disorder that must be investigated. All right, let's move on to another application of acoustic reflexes that you can use in any day in the clinic. In fact, this is one of the most powerful applications of the acoustic reflex, and one that should be applied in the evaluation of adults and children on a regular basis. And that is differentiating or making a distinction between someone who probably has normal hearing sensitivity versus someone who is most likely has a cochlear hearing loss. Now, obviously, pure tone audiometry can provide this information in most cases. But, as I've already mentioned, pure tone audiometry may be affected by factors such as cognition, memory, attention, motivation. Some patients will produce invalid pure tone findings. But the acoustic reflex is a reflex. The patient can't control it. It's kind of automatically produced when a sound, an adequate intensity sound, is presented to one ear, and we're measuring the stapedius muscle activity on the other side or the same side. So one way we can use this is in patients who are very young, children, who cannot participate in behavioral audiometry, but we can also use this same approach, predicting or differentiating normal sensitivity from sensory hearing loss with the acoustic reflex in any patient, children or adult. It's most useful to confirm or cross-check to verify the results of behavioral audiometry. It's also very useful in diagnosing very quickly, at the very beginning of an assessment, an audiological assessment, diagnosing a false hearing loss or an exaggerated hearing loss. Now, this may be someone who's actually a malingerer, somebody who's purposefully attempting to falsify a hearing loss, or it could occur in someone with some type of psychological disorder where they are giving the impression of having a hearing loss when in fact they have normal ears. Again, the acoustic reflex is not going to mislead you. It's going to tell you the truth about their hearing. If there is an acoustic reflex, and particularly for broadband noise stimulus, that type of stimulus, and that acoustic reflex is at a normal level for broadband noise, that the normal threshold would usually, for acoustic reflex, would usually be around 60 to 65 dB. And I'm going to show you that in a graph in a moment. So this is a very valuable way of verifying the validity of pure tone audiometry. Here's the graph I was referring to, and this is some from work I've performed way back in the 1980s. We all know that when you present a pure tone signal to measure the acoustic reflex, there can be considerable hearing loss, and yet the threshold for the acoustic reflex with the pure tone signal is somewhere in the 80 to 85 dB region. And as we present higher and higher intensities, of the pure tone signal, we'll still get a normal threshold. Now, if a person has a hearing loss that's sensory, it's a cochlear hearing loss, there's loudness recruitment. And so it's possible to continue to record a normal acoustic reflex threshold for tones, even up to hearing loss of 50 to 60 dB. Now, with the broadband noise stimulus, and if you look at for example, the TimStar Pro device for middle ear measurement, you'll see that among all the different stimuli, there's 500 hertz, 1,000, 2,000, 4,000. There's also broadband noise stimulus, and then a low pass and a high pass noise stimulus. But we're talking about the broadband noise, or BBN stimulus, right now. Well, my research and the research of Dr. Jerger and many others showed that as you get into people with greater degrees of hearing loss, the broadband noise threshold progressively is higher and higher. And I found that if you took maybe 1,000 people with acoustic reflex thresholds, and they all had different degrees of hearing loss, if you looked at all of the data, those people with broadband noise acoustic reflex thresholds better than 80 dB almost always had normal hearing sensitivity. And the lower the broadband noise threshold, 70, 75, 70, 65, 50, the more likely they have normal cochlear function. The broadband noise stimulus is activating the entire cochlea, and therefore it's going to be the lowest when somebody has a perfectly normal cochlea. If someone has a high frequency hearing loss, they don't have normal hearing in the high frequencies, that will reduce the effectiveness of that broadband noise stimulus, and their acoustic reflex threshold will be elevated. So I use this in the clinic all the time. Someone with a broadband noise acoustic reflex threshold of 60, 65 dB, which is very typical, try it out on the TimStar Pro. Go to the exhibit area and record your own broadband noise threshold. If you have normal middle ear function and normal hearing sensitivity, you'll probably have a broadband noise threshold well under 80 dB. And if you have a patient with that finding, you can almost always predict that their hearing sensitivity will be normal. If you then go to the sound booth and you perform pure tone audiometry, and maybe the results show a 40 to 50 dB threshold level, you must be suspicious. Be suspicious that that's not valid, because the broadband noise threshold predicted normal hearing sensitivity. So there are many applications of the broadband noise reflex threshold in promoting healthy hearing over the lifespan. It validates pure tone findings, and it's a very sensitive measure of cochlear status. Obviously, we're not even talking about the central auditory pathways, the brainstem pathways of the acoustic reflex. We'll get to that in just a moment. The next application of the acoustic reflex, this is extremely important in routine clinical audiometry with adults, is the detection of eighth nerve dysfunction. For over 40 years, I've measured acoustic reflexes in almost every patient, adult and child. And there have been on more than one occasion, I would have a patient who might have some unusual complaints. I can't use the telephone on the left ear. But then the audiogram shows relatively good hearing. Hearing's within normal limits in both ears. And you wonder, well, why is the patient having such difficulty using the telephone on one ear when their hearing sensitivity is normal? Perhaps even their word recognition in quiet is normal. Then you perform acoustic reflex measurements for ipsilateral and contralateral conditions. And you find that even though hearing sensitivity is quite good in both ears, there is no acoustic reflex whenever the sound is in one ear. So if the person's complaining about their right ear, they can't use the right ear on the telephone because they can't understand what people are saying, we find that when we put the probe in the right ear and the sound, ipsilateral right ear acoustic reflex, it's missing. When we put the sound in the right ear and the probe is in the other ear, we're measuring a right ear contralateral reflex, it's also missing, even though the hearing sensitivity is quite good. That is a very, very powerful indicator of retrocochlear or eighth nerve problem on the suspicious ear. Now, if the patient has no hearing in one ear or severe to profound loss, we will also get the same pattern. There will be no acoustic reflex whenever sound is in that abnormal ear. So here's an actual case to illustrate what I just said. On the left, you see an audiogram, and it's pretty much normal. We got the right and left ears separated. The only abnormality is at the highest frequencies. For the right ear, you see a slight decrease in the threshold, but all the other thresholds are normal and everything's normal in the left ear. Now, we would expect that person, if they have a normal middle ear, which they do, look down below, the tympanogram's normal, we would expect that person to have perfectly normal reflexes, but there's no reflexes at all with the sound in the right ear. None at all. The first thing I think about is a retrocochlear problem. This was a young adult college student who had an acoustic tumor, a vestibular schwannoma on the right side. So this is a very powerful application of acoustic reflexes in adults, just ruling out retrocochlear dysfunction. The next disorder we'll talk about is not even an auditory problem. It's a facial nerve paralysis or paresis. And we all have seen patients with Bell's palsy or traumatic temporal bone fractures to one ear who have facial nerve dysfunction. They may show some signs of that clinically when you look at their face, but when you perform acoustic reflexes, remember the efferent, or the final pathway from the brainstem down to the ear, involves the facial nerve, the seventh cranial nerve. So if you have a patient with Bell's palsy or some other etiology, Ramsay-Hunt syndrome, some other etiology for facial nerve paralysis, the acoustic reflex is a very, very useful diagnostic tool. Now here, let's just assume the person's concerns about the right facial nerve. If the patient has no acoustic reflex whenever the probe is in the right ear, and they have a normal tympanogram and perhaps normal audiogram, then we can rule out middle ears. They may even have normal OAEs. So we rule out a middle ear explanation. We rule out hearing loss. And it can't be an acoustic neuroma because that would affect the sound in the right ear. But here it's a probe problem. The abnormality is whenever the probe is in the right ear. That's almost 100% certain indicator. It's almost 100% predictor of facial nerve in that ear. So that's another valuable application of acoustic reflex as part of a comprehensive test battery in evaluating a patient before you begin management to prevent or at least minimize hearing loss. And here's an example of the audiogram for that type of patient. Normal hearing sensitivity in both ears, normal tympanograms, everything kind of looks normal, and yet there are no acoustic reflexes whenever the probe is in the left ear. This is a patient with left seventh cranial nerve disorder, Bell's palsy. Okay, we've got just one more application of acoustic reflexes that we'll discuss in this lecture. When we get to talking about objective assessment of hearing in infants and young children, we're going to come back to the acoustic reflex and talk about how it also plays a role in the diagnosis of infant hearing loss. But here we're focusing more on adult population, people who are being referred to us coming into our clinic because somebody has some concern about their hearing, perhaps the patient, a family member, a physician, etc. So now we're going to talk about brainstem auditory dysfunction. Not as common, but you will encounter it in a busy clinic, particularly in a medical center environment. So we know that the contralateral reflexes require activation of pathways in the brainstem. We've already looked at the diagram of the acoustic reflex pathways. So we stimulate an ear, the sound information goes up the auditory nerve on the side that we're stimulating, but then there are connections in the brainstem, the cochlear nucleus and the fibers that go from one side of the brainstem to the other, like the trapezoid body, and in the olivary complex on the other side. So if there's a brainstem abnormality affecting the auditory system, it could be a person's had a brainstem stroke, they could have a tumor, perhaps they have had some trauma that affected the brainstem. There's some etiology affecting the auditory brainstem. There may be no reflexes in the contralateral condition, and yet the ipsilateral reflexes, which only really involve the auditory nerve, the cochlear nucleus, and then right back down the facial nerve, those may be normal. So if you see this pattern, what I'm showing you here, where only the contralateral reflexes are elevated or abnormal, then you suspect brainstem. And this could be in someone who no one suspects has a brainstem problem, or it could be in a patient who's got serious balance problems and vestibular problems, or somebody who's complaining of headaches, or somebody perhaps who perhaps is at risk for a brainstem tumor. And this may be the first indication of an abnormality in the brainstem. So I have seen this pattern throughout my career. You won't see it too often, but it's very, very conclusive. Abnormalities only in the contralateral pathways. So if you have a patient with, if we went through the history already, if they have cardiovascular disorders, they have high blood pressure, if they're at risk for a stroke, you may see this pattern. It may be one of the earliest indicators that there's been damage in the brainstem. Many years ago, back in the 1970s, I saw a patient with this pattern. In fact, they had only one contralateral reflex was absent. The other contralateral reflex was present and normal, and so were the ipsilateral acoustic reflexes. And I was just a student at the time. I took this finding to Dr. Jerger, my mentor, who was my directing the clinic. This was at Baylor College of Medicine. I said, Dr. Jerger, this is unusual. This patient has acoustic reflexes that are perfectly normal in 3 of the 4 conditions, but with stimulation of one ear, the contralateral reflexes are absent. He really didn't believe it, but he said, okay, if you're sure of this, we will refer the patient to neurology. The patient was referred to neurology, and sure enough, they had a brainstem tumor. And so you will see abnormalities in both of the acoustic contralateral reflexes or only one. All right, we're now moving on from oral emittance. It was a long discussion, but I wanted to emphasize the clinical value of oral emittance, even in an adult population, and a population coming in, somebody's concerned about hearing or auditory function, and you're trying to evaluate them using the most sensitive and the most specific tools that you have. Don't forget to always include oral emittance, including acoustic reflexes. Well, now we move on to OAEs, otoacoustic emissions. They are the most sensitive measure of outer hair cell function. There's no better way to evaluate whether the outer hair cells are functioning normally. And almost everything that can damage the cochlea, almost all insults to the cochlea, almost all etiologies for cochlear hearing loss do involve the outer hair cells. So the outer hair cells are very delicate and they're highly metabolic, and it doesn't take much of a insult or a potential damaging effect, whether it's noise or ototoxic drugs or an infection, to affect the outer hair cells. And you will detect that with OAEs. OAEs are the most sensitive way to measure whether the outer hair cells are functioning well. And almost always you will detect hearing loss quickly if you utilize acoustic OAEs in your routine clinical practice. Now, the generation of OAEs obviously involves the outer hair cells, but other parts of the cochlea and other parts of the auditory system also play a role. So the outer hair cells are generating the OAEs. The movement, the motility of the outer hair cells in response to sound produce the energy that we record as OAEs. But other parts of the cochlea that are involved are the stereocilia on top of the outer hair cells, a special protein called prestin that's in the walls of the outer hair cells, the tectorial membrane, the tallest of the stereocilia on the outer hair cells is embedded in the tectorial membrane. So if the tectorial membrane breaks loose from the stereocilia of the outer hair cells, OAEs will be affected. Basilar membrane mechanics definitely play a role. The stria vascularis, as you see in this slide over in the far right, is the stria vascularis, the outer portion of the cochlea. And of course, that's where all the metabolism and energy that is required by the outer hair cells is produced. That's a very important part of the cochlear function. So if the stria vascularis has been affected by drugs or perhaps reduction in blood flow or oxygen to the cochlea, that will also affect OAEs. Now, even the middle ear is involved in measurement of OAEs because we must get the stimulus through the middle ear to the cochlea, and we must get the OAE activity from the cochlea back through the middle ear to the external ear canal. And of course, anything in the external ear canal, excessive cerumen, foreign objects, some pathology of some type, could affect OAEs. So OAEs are a very sensitive measure of the ear and specifically of the cochlea and more specifically of the outer hair cells. Let's talk just for a moment about the analysis of OAEs. Let's say you've recorded transient OAEs or DPs. How do you analyze them? Unfortunately, most audiologists do not use OAEs in a diagnostic fashion. Most audiologists will say the OAEs are present or absent, and that's inadequate. We need to determine whether they're normal or abnormal, and then if they're abnormal, are they actually present but abnormal, or are they totally absent? So here are the steps I would recommend, 5 simple steps for analyzing OAEs, whether it's transient OAEs or distortion product. First, make sure the noise floor during the measurement is adequately low. There should be no more noise than a typical normal adult would have in their ear canal during OAE measurement. So when you look at normative data for the amplitude of OAEs, usually that normative data will include normative data for noise. As a general rule, you want to try to keep the noise in the ear canal, minimize the noise to less than minus 10 dB. If the noise in the ear canal at the time you're recording the OAEs is less than 10 dB, then you'll probably be able to detect any OAE activity that might be found in that patient. Perform your analysis of the OAEs at all frequencies. Don't just look at one frequency or another. And make sure that the OAEs are repeatable. I would recommend that for DPOEs, you record them and then immediately record them again in the same ear in the same patient, and make sure that they get the same results for both of these recordings. So now we're ready to actually analyze the OAEs. The first question is there any OAE activity that's at least 6 dB above the noise floor? So the noise floor is adequately low, say minus 10 or lower. Is there any OAE activity that's at least 6 dB above that noise floor? If so, the OAEs are present. That doesn't mean they're normal, but at least there's some OAE activity. There are some hair cells, outer hair cells, functioning. The next question is, if the OAEs are 6 dB or more above the noise floor, are they within the normal range? Is the amplitude of the OAEs within the normal range? If that's the case, then we can be quite sure that all of the outer hair cells are functioning normally in that patient. So the 3 possible outcomes are normal, present and normal, present but abnormal, and absent. And here's a graph, a DP-gram, showing that. In the lower frequencies, the OAEs are normal. The symbols, which is the right ear for this, in this case, the symbols are close to the normal region. Every piece of equipment will have normative data. I've actually collected the normative data from many OAE systems. So here we have normal OAEs in low frequencies. Now when we get above 2,000 hertz, this is a patient who was a musician who was exposed to, played the violin and was exposed to high intensities of music. As we get above 2,000 hertz, you can see there are some OAEs present. They're well above the noise floor, and yet they're below the normal region. They're below the lower limit from the normal region. And then in the highest frequencies, there's no OAEs at all. The OAE, apparent OAEs are just down with the noise. So you may get any combination of these findings in a single patient, a single ear of a single patient. Okay, very quickly, we're going to wrap up our OAEs with 2 more slides. One is when you compare or utilize OAEs and then compare the results to the audiogram, they almost always agree. That's what we would expect. So when the audiogram's normal, the OAEs should be normal. When the audiogram's abnormal, we would expect the OAEs to be abnormal. But that's not always the case. The value of OAEs is they're totally objective, and they give us different information than you will receive from an audiogram. The audiogram is telling us basically, can the person hear faint sounds? OAEs, however, are providing physiologic information on the integrity of the outer hair cells in the cochlea. So in most cases, there'll be agreement. But in some cases, OAEs may be abnormal. You see this quite often. You see this in a person with noise exposure or someone with diabetes that's beginning to affect the blood flow to the cochlea. Or you see it in somebody who's just being given some ototoxic drugs. Or you might even see this in a patient who complains of bothersome tinnitus. The audiogram's normal, and many audiologists would therefore conclude there's no problem with hearing, except the OEs are not normal. If the OEs are abnormal, and yet the middle ear is normal, they have normal tympanograms, acoustic reflexes present at normal levels, there's no air bone gap, then there must be a problem with the cochlea. It's not being detected with the audiogram. OEs are a far more sensitive measure of cochlear function than the audiogram. So the first explanation is outer hair cell dysfunction that's subclinical. It's not yet showing up in the audiogram. And that is valuable information. Probably of all the findings we're talking about for promoting healthy hearing, this is the most important. When you evaluate a patient whose audiogram is still normal, but whose OEs are beginning to show abnormality, you have an opportunity to counsel that patient and to prevent further hearing loss, whether the cause is ototoxic drugs or noise or some other factor. Now, there's another possibility. You perform OAEs first, they're normal, but then you get the patient in the sound booth and their audiogram's abnormal. Now, what could be the possible explanation for that difference? Well, the first thing we want to rule out is technical problems. Were the earphones in the right place? Did the patient understand the instructions? Make sure there's no problem with the equipment. Another possibility, very rare, would be there really is a hearing loss. The audiogram's accurate, but the hearing loss is due to inner hair cell dysfunction. So the inner hair cells are not functioning properly, but the outer hair cells are normal. That's why we have normal OEs in that patient with the hearing loss. This is very unusual, and it's almost always a congenital problem, and almost always is going to be detected at a young age. But that's a possible explanation. Another, probably more likely, explanation is the OAEs are normal because they are measuring just outer hair cell function. The audiogram's abnormal because there's a neural problem. It could be an acoustic tumor. It could be neural fibromatosis if it's in both ears. It could be any number of explanations. It's very unusual, but you will detect it right away if you perform OAEs, because they'll be normal in that case when the audiogram is quite abnormal. And then the other possibility, which is perhaps more common than the inner hair cell or the neural, would be a patient who has a false hearing loss. It's either a psychological expression of or explanation for the false hearing loss, or they're actually purposefully trying to convince you as the audiologist that they have a hearing loss when in fact they don't. So there may be psychological explanations, or there may be financial compensation explanations, but one way or the other, the normal OAEs make you very suspicious that they don't have a hearing loss. You must follow up with that patient. Now, if I have already recorded broadband noise acoustic reflexes and the broadband noise reflex threshold is 60 dB and they have normal OAEs, I'm convinced that that's not a real hearing loss. So then I have to find out, are they trying to falsify the hearing loss, or is it kind of a subconscious psychological manifestation of a hearing loss? One way or the other, the OAEs help me to detect it or diagnose that problem at a very early stage. Okay, so we're moving right along here, and let's just wrap up our discussion about OAEs in adults. And next lecture, we'll talk about OAEs in children. Well, there are many applications. It's not uncommon for audiologists to say, well, I don't use OAEs because I mostly evaluate children. I don't evaluate adults. I evaluate adults, I don't evaluate children. In other words, someone who's primarily providing hearing assessment to people who are going to end up needing hearing aids perhaps, they don't feel like there's much value in OEs because they have pure tone audiometry that they can used to evaluate hearing. But that's really not the case. OAEs still provide valuable information. We can use them as a screening technique in people who are at risk for noise exposure or music exposure. Very quickly, we can rule out cochlear dysfunction in those patients. I've already mentioned how OAEs can be used in tinnitus assessment and counseling. If a patient has bothersome tinnitus, even if their audiogram's normal, an abnormal OAE finding will validate, prove that they really do have an auditory problem. It's not just in their head. They're actually experiencing tinnitus because the hair cells in their ear are not functioning normally. Of course, ototoxicity monitoring in adults is another application. We just talked about false and exaggerated hearing loss. We've also talked about using OAEs to differentiate cochlear from retrocochlear hearing loss. There are distinct patterns of OAEs in Meniere's disease. Some patients with Meniere's disease have abnormal, absent OAEs. Others have actually bigger than normal OAEs. You've all probably heard of hidden hearing loss and synaptopathy, damage or dysfunction of the auditory neurons beyond the inner hair cells. That can be, OAEs can be useful in those patients. And then even as an indirect measure of intracranial pressure in patients who have had some kind of head injury, maybe a sports injury. So there are many applications of OAEs in adults. Okay, we're getting toward the end of part 2. It's going to be shorter than part 1. So now I'd like to present just a couple of hypothetical but case scenarios that are based on real patients. I put these cases together to illustrate some points, but I've actually seen patients with exactly these findings. So we're going to just show you how this updated test battery, going beyond just air conduction, bone conduction, pure tone audiometry, and simple speech audiometry, including OAEs routinely, including tympanometry and acoustic reflexes routinely, including speech perception in noise routinely, can totally change the way you diagnose hearing loss and the way you manage hearing loss. So the first case is a 55-year-old male who's coming in because he has tinnitus. He has a ringing sound in his ears and it's really bothering him. It's disrupting his quality of life. But his wife comes in with him and she points out that her husband is really not hearing her very well and even struggling to hear the children. And nobody can seem to communicate with this guy when they're in noisy situations, either at work or recreationally. If they go out and there's background noise, they go out to a restaurant, this person really struggles to hear. So that's his chief complaint. We asked this man in our history about his ears, and he says, well, I've never had any problem with my ears. I mean, I'm healthy, a healthy person. I've never been to an ear doctor in my life. Even when I was a child, I never had any ear infections. He thinks he has normal hearing, and his family doctor says, I don't see any problem. I mean, I'm talking to you here in my exam office. The family doctor might clap their hands, and the person seems to hear him. So the family doctor doesn't think they have a hearing problem. They've never had any ear problem, ear disease. But we find out that this man, 55-year-old, has been working around noise all of his life. And when he's not working, he's riding a motorcycle, he shoots rifles, he's got recreational noise exposure. Maybe even goes to a concert every now and then, listens to very loud music. And our history also shows that he has a very unhealthy habit. He smokes. He's a heavy smoker. He smoked more than 1 pack of cigarettes a day since he was in his 20s, so over 35 years. Now, based on what we've discussed so far, automatically you're concerned. I'm hoping you're concerned that even though his family doctor thinks he has normal hearing, and this guy doesn't really think he has a hearing loss. His family does, but he would deny that he has a hearing loss. He does mention the tinnitus. We would be very concerned. I would expect that he has cochlear damage of some type. He's definitely at risk for it. He's at risk for sensory hearing loss or at least cochlear damage. He's certainly, we would be able to confirm tinnitus. We would think so. He complains of bothersome tinnitus. And based on his smoking habit and the difficulty he hears and has hearing in background noise, He might actually have some central auditory dysfunction. So let's get into the assessment. Well, if you look on the right-hand side of this slide, we have the audiogram, and just assume that both ears are the same. You'd say, well, his hearing sensitivity is not bad. He actually has normal hearing sensitivity in the low frequencies and is just about normal in the high frequencies. So at first you might say, well, this doesn't make sense. Everybody thinks he's got a hearing problem, but in fact his hearing's quite good. Well, only his hearing sensitivity is good. His otoscopy findings were normal. His speech reception thresholds, if we did that, well, they were normal. His ability to repeat words, his word recognition and quiet, greater than 90%. So many audiologists would stop there and they would say, oh, sir, you should stop smoking, but at least you don't have any problem with your ears. And the wife would be saying, and the family members, what are you saying? How can you say that he has no problem with his ears? He doesn't understand us when we're talking to him. He struggles when he hears. But we'd say, no, everything seems to be just fine. Well, that would be a mistake because we didn't do an adequate assessment. We didn't complete an adequate assessment. We might counsel him about tinnitus, but we would really be letting him down. We wouldn't be providing him with the services that we really should be providing. So let's now go on to the test battery that we've been discussing, where we went beyond air conduction, bone conduction, and simple speech. Well, the OAEs in this person were very abnormal. In fact, they were only within the normal limits in the very low frequencies. If we look in the lower left-hand corner of this slide, those are dp grams. And those two horizontal lines, those define the normal limits for for OAE amplitude. And in fact, his OAEs were absent in the high frequencies, even though his audiogram showed only a very, very mild hearing loss. So his OAEs unequivocally show cochlear dysfunction bilaterally. Could be due to the smoking, could be due to noise exposure, probably a combination. And then we administered speech perception and noise tests. Well, that would make sense. People say he has problems in background noise. We really need to do that. And it turns out he needs a much bigger signal-to-noise ratio before he can respond consistently to the test sentences. So he has a serious speech and noise problem. It's not the worst problem that we've ever seen, but clearly the speech perception and noise tests confirm that he does not hear well in background noise. So now we've got more information on this patient that will help us to develop, to counsel him, but also to develop an effective management strategy. So based on the impressions of the original test battery, we would say, well, you don't have much of a problem with your hearing, and we'd send him on his way. But because we went beyond air conduction, bone conduction, and speech, we have clear evidence of cochlear dysfunction. We know he's having problems with speech perception and noise, so we manage him in a different way. We really emphasize hearing protection. He's got to protect his ears when he's around loud sounds. We talk about hearing protection devices, all kinds of devices. And we're going to follow him up in the future. We're going to bring him back within 3 to 6 months to make sure he's actually following our recommendations. We talk to him about tinnitus. We explain, yes, you have tinnitus because you have damage to your cochlea. It's very logical. We're not surprised. Even though your hearing ability to hear faint sounds is not too bad, you're really struggling because you've got damage to these hair cells, and it's probably due to the noise and also the smoking. We'll tell them about the connection between smoking and cochlear deficits, smoking and hearing loss. We'll get the family doctor involved to help us to get this patient to stop smoking and to start protecting his ears. And we may even follow up in 6 months, not only to document that he's following our recommendations to protect his hearing, but maybe also to conduct some more detailed assessment of auditory processing. So you can see that our management of this patient is much more specific, and it's expanded tremendously because we have this information from OAE, speech perception, and noise. Okay, a second case, and then we're going to wrap things up. Case scenario 2 is a 75-year-old female. her chief complaint is difficulty communicating in noisy environments. And actually, she's not the one that really is complaining about this so much. Her children and her family members are convinced she's got a significant hearing loss. And she doesn't like to go out socially anymore. She doesn't like to go places because she just can't seem to understand what people are saying. Now, when she came in, we noticed that the daughter was sitting in the waiting room filling out the history form for her mother, the 75-year-old woman, and asking the woman the questions and then answering them. And we also learned that the daughter drove the 75-year-old woman to the clinic. The woman did not drive herself. And we're beginning to see a pattern that perhaps this 75-year-old female is not able to function independently without her daughter helping her. And then confidentially, as we're beginning to perform the test, the daughter whispered to us that her mom, she's really concerned that her mom's memory is getting very poor. In recent years, her memory has deteriorated, and she doesn't seem to be able to focus on what she's doing, and her attention is not good. She's forgetting things, where she put things, there's concern about cognitive functioning. Now, this woman also has never had any problem with her ears, never seen an ear doctor, never had an ear infection to her knowledge, and her ears look just great with otoscopy. So we're suspecting that she might have a sensory hearing loss, presbycusis or age-related hearing loss, but she also could have some central auditory processing difficulties. So let's look at her audiometric results. Well, she has, if you look to the right, she has a high-frequency, sloping high-frequency hearing loss. It's a sensory hearing loss. It's not unexpected for a 75-year-old as a result of age-related factors. Her no air bone gap, middle ear function looks normal. We did bone conduction if we use the traditional scenario. Now, I might not do that with this patient because I might have the patient might have normal tympanograms and normal reflexes, and she's never had any middle ear problems. But if you did do bone conduction, it would show no air bone gap. And in quiet, actually she does pretty well with word recognition, 92%. So that's the traditional test battery. We might talk about a hearing aid with her, but we would really be underestimating her hearing difficulties. Now let's expand the test battery as we've been discussing, and now we're going to go beyond just the simple test. We might perform oral admittance to begin with, I would, and if the tympanograms were normal, and if she had normal ipsilateral reflexes, I wouldn't do bone conduction. I'd save that time and spend that on word recognition, on speech perception and noise. I would find that her contralateral reflexes were elevated, even though her ipsilateral reflexes were normal, and that would provide me with the first evidence that this older woman had some central auditory difficulties. And then I'd find that if I administered a test of sentence perception in background competition, people speaking in the background, the synthetic sentence identification, I would show that she had a horrible time even in just normal everyday listening situations where the sentences she was listening to were the same intensity level as the background speaking that she was also hearing. So I would have clear evidence of central auditory deficit at the very beginning of this assessment, even though the audiogram was only showing a mild high-frequency loss, and even though word recognition in quiet was quite good. So how does the expanded test battery, or how do the findings of the expanded test battery contribute to the management of this patient? How can we promote healthy or better hearing with her, or prevent further hearing loss? Well, certainly the outer hair cells, we would confirm that they are damaged. That's due because of the OAE findings. They were abnormal. The central auditory findings are very concerning. We would want to recommend a referral to a psychologist for cognitive testing, perhaps a referral to a neurologist to evaluate her central nervous system functioning, make sure that this woman is not going to have a stroke, or maybe has already had a stroke and nobody knows about it. excuse me, and as we talk to her and her family members about hearing aids, we also want to talk to them about FM technology, frequency modulation technology, or dual, multiple microphones, some way for her to hear more effectively in background noise, because we know that's a major problem. So with her, we would also get her family doctor involved. We definitely want to refer to psychology. We'd take an approach that was much more focusing on what the problems she's having, rather than just giving her a hearing aid and saying that should take care of your problems, because the hearing aids are only going to help her to some extent, but she obviously has problems beyond just the peripheral hearing loss, and we'd want to follow her very, very closely. So I think you can see that by using a comprehensive test battery, rather than just air conduction and bone conduction, pure tone audiometry, and simple speech audiometry, we can evaluate our patients more accurately, and we can manage them more effectively. We're going to wrap up by talking about how this approach, practicing preventive audiology, involves not just us, but other disciplines, healthcare professionals that we can interact with as professionals, as colleagues. And in the interaction with other health professionals and managing your patient, rather than just going it alone as an audiologist, just recommending hearing aids and leaving it at that, this will not only help the patients, but it'll help your practice. You're going to start getting referrals from family practitioners, from endocrinologists, from cardiovascular people, from people you'd never thought of getting a referral from, such as a nephrologist, somebody that specializes in kidneys, or a psychologist. So this concept that I'm discussing, promoting healthy hearing, practicing preventive audiology, it's not only good for the patients, it's actually going to be good for your practice. And this is not just a unique concept. There is quite a bit of interest in the literature, in research, on this concept of expanding audiology to be part of a multidisciplinary team. And then this connection between the comorbid conditions and hearing loss is our invitation to do this. And so here are various health conditions that are associated with hearing loss, and we should be interacting with the medical specialists and non-medical non-medical health professionals like psychologists, dietitians, who are trying to solve the same problems. So you will find guidelines and kind of a template for this new concept of practicing preventive audiology in the literature. Some of this information, some of these articles are actually from around the world. They're not just in the United States. Here's an article from in a publication from Australia, where there's an entire systematic approach to looking at hearing assessment and management of hearing loss in the context of chronic health conditions, rather than just focusing on the audiological findings and on the audiogram in specifically. So I encourage you to check out some of these articles as you begin to think about restructuring your audiological practice. Here's some general guidelines, and I'm not going to review this in detail because we've been discussing it now for more than an hour, but these are general guidelines for implementing this new strategy that I've been talking about. Expanding your patient history to include general health as well as hearing health. Selecting auditory tests based on the patient's complaints and their family's complaints and what you find in the history. Don't just administer a simple test battery, the same simple test battery on every patient. Try to select the procedures you will use to evaluate the patient based on what their problem is most likely going to be, and that comes from history and chief complaint. Counsel the patients about the importance of lifestyle, a healthy diet. If they smoke, they need to stop smoking. If they don't exercise, they need to exercise more. Talk about preventing hearing loss. When you have a patient with a normal audiogram and perhaps OAE abnormalities, that's your invitation to counsel them about preventing the development of a hearing loss on the audiogram. You have an opportunity to give them an incredible gift, and that gift would be hearing sensitivity within normal limits throughout their life, perhaps. And without you intervening at that stage, it's likely they will develop a hearing loss. And then they'll come back to you in 30 or 40 years and they'll want you to do something about it. And unfortunately, at that point, it'll be too late. It'll be a permanent hearing loss. So try to prevent hearing loss whenever possible and minimize further hearing loss whenever possible. And that means interacting with a wide range of physicians. Educate physicians about the importance of hearing, but also the connection between the problems that they see in their practice and the hearing problems that you see in your practice. So here's a list of the types of physicians that you should be interacting with on a regular basis. Not just otolaryngologists, not just pediatricians, but all of these. And even non-medical professionals such as psychologists, optometrists, speech pathologists, and others. So I will conclude by encouraging you to expand your audiological practice, go beyond hearing, go beyond just the audiogram, and you're going to find it very rewarding. You're going to find that you're helping your patients far more than you have been, and you're going to find that you're getting more referrals from sources, from other referral sources that you really had never even considered in your audiological practice. I hope you enjoyed this presentation. At the end of the day, your day, it'll be the beginning of my day on June 9th, we will have a question and answer session, and I look forward to getting hearing any questions that you might have about how you can expand your practice, update your practice, and start preventing hearing loss whenever possible and mitigating hearing loss in patients who already have evidence of a hearing loss. Thank you very much.